Yeah, so thank you guys for inviting me, and kind of as you referred to, we really appreciate just the support of COLONTOWN in general. This goes beyond just kind of, as you mentioned, your support for the COBRA trial and the BRAF trials as well, which, you guys are obviously incredible, in mobilizing patients, through social media. But I will say more experientially as well, this group means a lot to my patients, and it is common for me to have that patient come to MD Anderson who's newly diagnosed with colon cancer and is very understandably afraid, and to hear kind of their testimonies with how helpful COLONTOWN has been in helping them, and other patient advocacy groups too have been in helping them to understand kind of what's going on with the shock of news in their lives. So we just want to say we as oncologists appreciate your commitment to helping patients in this effort we're all fighting against. I will say I realized that Dr. Corcoran had presented I think a week or so ago, so some of this may overlap. I'll try to kind of interject my own opinions about this, but there will be some overlap. There may be some slides that we haven't published yet that I did want to at least just share our data. So when I hit those slides, I want to share that kind of why we think what we think, but also just maybe ask for those particular slides, just kind of keeping those confidential because we haven't really published this data yet. So I'm going to be talking about kind of combining targeted therapies with immunotherapy, and maybe not using a one-size-fits-all approach for the management of BRAF-mutated metastatic colorectal cancer. Sorry. Okay. So I always just feel that it's important to start out with a patient presentation just to kind of put into context what we're up against here. And this was a patient that I met during my first year on faculty at MD Anderson. It was a 35-year-old lady from the Valley in Southern Texas who presented to the ER with abdominal pain, no past medical history at all. She had a 13-year-old son, a single mother. When she presented with abdominal pain, her surgeons locally felt that she had issues with her gallbladder and took her to surgery to remove the gallbladder, and were surprised instead to find a large transverse colon mass with diffuse metastatic disease in the peritoneum that was responsible for the abdominal pain. The pathology, ultimately showed a microsatellite stable BRAF mutated CRC tumor. And she then came to MD Anderson where, when she presented to MD Anderson, she already had developed a large bowel obstruction from her tumor. So this was in 2016. We started her on treatment with FOLFOXIRI. And she had some initial clinical improvement, but unfortunately within 3 months of, what is really throwing the kitchen sink at this tumor in terms of cytotoxic chemotherapy, she was already developing signs of clinical and radiographic progression. And within, 4 months of her initial presentation, the single mother was transferred to hospice. And it was horrific to watch this unfold, as a, new oncologist at that point in time. And I think this just really speaks to the challenge we face with BRAF mutated colorectal cancer. We recognize that this is a unique population with regards to clinical outcomes. As I've alluded to, the responses to chemotherapy aren't great, as we're used to seeing in our BRAF wild type patients. We recognize the unique pathology here just in terms of where these tumors, commonly arise from and how they look under the microscope. And with the genome as well, we'll talk about later, the high tumor burden may extend beyond the association with MSI high into the MSS setting as well. But also it's unique with regard to the epigenome. And we recognize these to be hypermethylated tumors. And I think that this still represents an untapped biology that is potentially targetable with regards to this particular subpopulation of colorectal cancer, and possibly, with respect to the transcriptome as well. And we'll talk kind of about CMS correlations a little bit later too. So we're seeing a unique and challenging, but potentially intervenable clinical presentation. And I'll kind of go through these slides quickly because we all recognize, that the BRAF, mutations, even though it's typically called, an uncommon subpopulation of CRC, when you still consider it's 5 to 10% of all the patients who have CRC, and colorectal cancer represents one of the top causes for cancer mortality in the United States, by absolute numbers, it's still a large fraction of patients, who are faced with the challenge of BRAF mutated metastatic CRC. And unfortunately, kind of as we all know here, the successes, of targeted therapies in terms of response rates that, other cancer types see with the same exact BRAF mutation, we just don't see those, in data that Dr. Kopetz and then Dr. Corcoran had shown with BRAF monotherapy and BRAF MEK combination therapy. Just we don't see either the response rates or the survival outcomes that we're accustomed to seeing in the context of other solid tumors as well. So this oftentimes when I hear people, say that we should be treating tumors agnostically to the primary and according to the molecular subtype, I always just cringe when I hear that, because I don't think that again, that's a one-size-fits-all approach. And I think that the BRAF V600E story for colorectal cancer is a very good example of why we can't, practice under such an umbrella. This is just kind of data that, again, we're all familiar with from, 8 years ago now, just kind of showing that, why in the context of CRC, that blocking the BRAF V600E oncoprotein, with the agents that work in other contexts don't work, as well. Kind of this upregulation of MAP kinase signaling that you get by kind of this constitutive activation of, I think I say this to say, and again, I don't, correct me if I'm wrong here, but I think I can probably go pretty quickly through the next couple of slides. I think this group, fully understands the recent clinical trials which have led to clinical outcomes or new clinical options, for these patients. But it was kind of really exciting, I think, to be involved early on with Dr. Kopetz, as a fellow even, and working on the SWOG protocol. And kind of seeing this translate from, an idea in in data that was coming out of the lab to showing some benefit in patients. And I think the exciting thing, and we really preach this to our fellows who train at MD Anderson, is that, we always hear this kind of term bench to bedside medicine. But the BRAF story to me is such a great example of bench to bedside medicine, but also bedside to bench medicine as well. And I think that, what we're learning and seeing in our patients now is translating into, new ideas and hypotheses, which are, hopefully being parlayed into kind of next generation clinical trials. I think the other caveat as well, as we all recognize as patients and as loved ones and as providers, is that even though it is exciting to see some of these data of improved survival outcomes in the BRAF mutated context, the unfortunate reality is that such a benefit is short-lived and certainly begs the need to do better. So kind of as a fellow at MD Anderson, I worked with Dr. Kopetz to look at kind of resistance model, why patients may get resistant. And we looked at PDX models, patient-derived xenograft models, where patients would go to surgery or have biopsies, and we would implant these tumors into mice. And we noticed that we had a model in the lab that surprisingly was very responsive to BRAF inhibition alone with vemurafenib. So we treated these tumors we took this tumor, we implanted it in 10 to 15 mice, and then we treated these mice with vemurafenib. And you can kind of see the average, for the growth curves here, but eventually by about 2 months out, all of these tumors were growing resistant to vemurafenib despite having an initial response to therapy. So we had 10 to 15 different mice models which had come from the same parent-derived tumor, and we sequenced these models, or we sequenced each of the tumors, and we're very interested to see that kind of, as you can see for the different mice, that we saw different mechanisms of resistance arising in each of these models, each of which had the potential to propagate MAP kinase signaling that we weren't seeing at such high allelic frequency, in the paired controls that had not received vemurafenib. We looked at a model too that was a different model that was, initially kind of had disease control with vemurafenib cetuximab, and we saw similar results. In PDXs, we were seeing acquisition of acquired KRAS mutations. This is something that in the vemurafenib study, they had signal of when they went to the baseline samples of these patients and looked in their plasma. Droplet digital PCR sequencing showed the presence of very, very low allelic frequency of KRAS mutants. You can see kind of 0.21, 0.31%, that were present at baseline that are oftentimes below the limit of detection of assays that were available at that time. When we looked at patients who were treated with on a phase 1 trial at MD Anderson with vemurafenib, cetuximab, and irinotecan, we saw that in the black here you see the relative allelic frequency of the BRAF V600E gene and ctDNA. But again, we were finding in patients as well the same thing that we had seen in the PDX models, that there were these acquired oncogenes showing up in the resistant setting that had not been present in the pretreatment specimens. So our question then, at that time, and this is the data that we took to Array when, I think when Kopetz was pitching the Beacon approach, was can the addition of the MEK inhibitor overcome the resistance to BRAF EGFR targeted therapies? I also think kind of with the SHIP and SAS inhibitors, which are kind of coming out as well, this also kind of represents something we're thinking about kind of moving forward as well. And again, what we saw in our PDXs was, again, when these tumors grew resistant to vemurafenib Cetux, if we added a MEK inhibitor, we could see sensitivity. And I think that Corcoran and his group, beat us to the punch in publishing this data, but we certainly felt that what we were seeing in the lab were being validated by his group as well. And so again, it made a lot of sense to us. So as we all know, that led to the kind of these thoughts led to the creation of the Beacon study. And this is kind of flipped here, but the overall response rate, of 26% with the triplet, the 20% with the doublet beat that of irinotecan and cetuximab. And as you guys are all aware, the addition of the MEK inhibitor didn't add any overall survival difference between BRAF and EGFR. And very excitingly, this should actually be changed. Incrafenib cetuximab in February or April of 2020 became FDA approved. So this was obviously super exciting for us and for our patients as well. So one of the questions that comes up with our patients when we talk about this in the clinic is, is binimetinib, will it ever, is it a non-viable option for the management of patients with BRAF mutated colorectal cancer? And I honestly don't fully know how to answer this question, because I kind of struggle with this idea that again, there's a one-size-fits-all approach for patients with BRAF mutated metastatic colorectal cancer. I think that we realize clinically these are heterogeneous patients, that probably biologically these are heterogeneous patients as well. And just kind of talking out loud, it just seems like kind of when we manage these patients that we oftentimes get a lot of more mixed responses in the BRAF mutated context than we do in maybe the BRAF wild type. I don't know if that's a thing. I'm actually just kind of talking out loud right now, kind of saying that. I haven't really looked into that, but it's not you just see this like more, I think, than kind of in the BRAF wild type, where if patients are going to progress, all of their spots are going to be kind of progressing together, whereas and oftentimes, you'll have, responses in, 2/3 of the lesions, and then, massive changes, in the opposite direction and, the other third. So again, I think that it's the underlying biologic heterogeneity as well, is very interesting and points to the challenge of treating this disease. We published this data, or we presented this data at ASCO last year. It's under review right now for a manuscript, but just kind of like, looking into this, we looked, kind of at our cohort of patients at MD Anderson, who had been evaluated since 2005, and we found 187 patients with BRAF mutated MET CRC, who were evaluated at our institution. And we just asked a simple question: if we take both ends of the spectrum and compare the differences, what do we see? It wasn't surprising that in the better survival group that there were more MSI high patients. Almost 50% of the patients in whom we had data on, were MSI high tumors. But I think that one of the really interesting things as well is that the median survival from the time of metastatic disease and this longest survival, was 84 months. And in the lowest survival, it was 8.6. And I think that kind of when, we as oncologists see a BRAF mutation, our minds automatically go to this, lower end of the spectrum. But I think that we have to kind of keep open minds that there are patients who do have good survival outcomes. When we looked at what is driving out survival, in this longest survival group, what's driving long survival outcome? And we saw that was also heterogeneous as well. Some of these patients were able to go to surgery, and as you can see in the black line here, many of these patients remain disease-free despite having an initial diagnosis of BRAF mutated MET CRC, 5, 6, 7 years out. But interestingly, and as we would expect, kind of as immunotherapy has unfolded, patients who were MSI high were also seeing kind of good long-term outcomes. Interestingly, one of these patients as well had an MSS tumor. But again, there were 7 patients that we found who were doing fairly well for long periods of time on MAP kinase targeted therapies. This included BRAF EGFR options, BRAF MEK options, and BRAF inhibitors alone. So there is, some suggestion here, to us that there may be this subpopulation of the BRAF mutated who just need targeting of their MAP kinase, and their particular tumor is addicted to MAP kinase signaling in the same way that perhaps an EGFR mutated lung cancer may be addicted to that EGFR mutation and be uniquely sensitive to tyrosine kinase inhibition in that context as well. So I say that to say that even the drivers for favorable outcomes in a setting are heterogeneous and do not always conform to, what providers, can assume. So I talked about how, this is, still an ongoing, I think, bench to bedside to bench and back to bedside success story. But, how can we lift that tail further? Obviously, in the MSI setting, response rates, even with a concomitant BRAF V600E mutation, is very good for anti-PD-1 with or without anti-CTLA-4 therapy. But unfortunately, still within the BRAF mutated context, we feel that the MSI highs, that concomitant microsatellite instability is still a minority of the patients with BRAF V600E tumors. So this is where I kind of start getting a little bit more in just to our data, which we haven't published yet, but I did want to share with you. If the majority of, we think of BRAF V600E, tumors as being kind of high tumor mutation burden, and oftentimes, I think the assumption is that, well, there's this association between microsatellite instability. We all know that MSI high tumors have higher mutation burdens, and so that's the reason that that BRAF V600E tumors, carry this association with having high tumor mutation burdens. And we actually looked at four data sets that were available to us: the nursing health data from Memorial Sloan Kettering, data from the TCGA, and then from internal data we had at MD Anderson. And we said, let's pull out the MSI high tumors and let's look at just the MSS tumors and look at the patients who are compare BRAF mutated tumors with the BRAF wild types. And we saw the same trends across all 4 data sets, that in general, MSS BRAF V600E mutated tumors harbor higher tumor mutation burdens relative to their MSS BRAF wild type counterparts. So this may not be something that's just MSI high driven. And, if that's the case, this may argue for some role of immunotherapy as a component for the MSS BRAF V600E story. We also, we're excited to see data that was published in Science last year from Dr. Bardelli's group in Milan, where they kind of looked at BRAF V600E CRC cell lines and showed that when you treat these with dual BRAF EGFR targeting, you induce, in terms of expression, a loss of expression of the mismatch repair proteins and can kind of create this transient MSI high-like state. So if that's the case, does that make sense that dual, or I guess triplet BRAF EGFR plus PD-1 therapy, would make sense in this context? And this is something that we had seen as well. This is data we haven't published yet, but this is from an expansion cohort of patients who were treated with vemurafenib, irino, and cetuximab, patients with BRAF V600E met CRC. And this is an example of a patient with a microsatellite stable tumor, but you can see prior to treatment, you don't see a lot of really immune active T cells within the tumor microenvironment, but that upon treatment with a BRAF EGFR inhibitor, you do see recruitment of activated CD8 positive cytotoxic T cells within the microenvironment. So, so that suggested to us that, there may be a role, for BRAF EGFR plus immune checkpoint therapy, kind of when we were pitching these concepts years ago in our initial letters of intent. Let's talk about CMS. We all, I think, all recognize the role of CMS biology, and that again, CMS1, is kind of the immune active group of subset of CRC tumors, and again, often associated with microsatellite instability. We also recognize that BRAF V600E tumors, kind of aggregate to CMS1 oftentimes as well. And so our question again was, is this association uniquely inherent to this association between MSI high CRC with BRAF V600 mutations, or can you see this in the MSS setting as well? So we looked at data from the SWOG 1406 data, and again, this hasn't been published yet either, but will be kind of forthcoming. And we looked specifically at in the red here from the SWOG study. Within the MSS context, the relative distribution of BRAF V600E tumors, and again, as you can see, almost half of the MSS BRAF-E tumors were CMS1. The other kind of half was, or the other kind of large proportion was CMS4. And this is different than what we had seen with an internal cohort of patients at MD Anderson who had MSS BRAF wild types, where you see a very low fraction of CMS1 within the BRAF wild type MSS context. So again, what we're seeing here is that within this MSS CRC population of patients, there may be some enrichment for a group, at least, of BRAF V600E MSS tumors for this more kind of immunologically hot CMS1 phenotype. We recognize from data that was published, by several groups several years ago that RNA signatures can indeed further subcategorize BRAF V600E tumors. BM1, the BRAF mutation 1 subgroup, it tends to be more of a kind of KRAS MAP kinase, whereas the BM2, is more, consistent with cell cycle deregulation. And again, you can see here, kind of when they look by CMS subtypes as well, you see kind of what we had seen in the prior slide. In the group where you have more MSS BRAF mutated tumors, you start seeing more CMS4 as well. And I think that it's a little bit early to know how this will kind of play out, but again, kind of argues for the heterogeneous subpopulations within the BRAF V600E context. So I think that, this was, reason that we were thinking, about the BRAF EGFR PD-1 combination. And, we were very excited to kind of see Dr. Corcoran's data that, he presented earlier this summer in virtual Barcelona. And then I think to you guys It sounds like in the recent past here, looking at the dabrafenib, trametinib, spartalizumab combination. So not exactly the same idea as ours, just kind of given the MEK in lieu of the BRAF. But I think that kind of one of the things that really struck out to us, and was the fact that you don't see a whole lot of kind of toxicity with this combination. When we approached Array with this in BMS with this idea several years ago, I think that they internally were worried a lot about the skin toxicity that you were going to see with these combinations. And I think that his early data is suggesting this is a fairly well tolerated regimen. But very interestingly, even though the data are still very early and immature, the gross numbers, just comparing the same BRAF MEK combination with or without a PD-1, I mean, it's very encouraging. It's very encouraging. And similarly, I think that he saw, kind of with this slide, similar to what I had shown you guys with our multiplex immunofluorescence slide, or data several slides back. But again, that BRAF MEK PD-1 does seem to recruit active T cells to the tumor microenvironment for hopeful cytotoxicity. So this kind of led us to our concept at MD Anderson, which is now enrolling. It's a trial looking specifically at MSS BRAF V600E mutated CRC, for patients who have not had prior BRAF, EGFR, MEK therapies, or immunotherapy. I think his trial may have been a little more broader in its eligibility criteria, but this was the population we wanted to look at first to kind of see signal. And we put 11 patients on, kind of amidst the COVID pandemic and having to stop it for two 30-day windows to evaluate toxicity, given the fact that this hadn't been looked at, this combination hadn't been looked at before. And so we've enrolled, fairly quickly under this trial. And what we're seeing is that just kind of, as Dr. Corcoran has shown, the safety data, is very promising for this combination as well. This is the selected eligibility criteria for our study. Again, MSS BRAF V600E adenocarcinoma of the colon or rectum, at least one but no more than 2 prior lines of systemic therapy, and then excluding prior BRAF MEK or other anti-EGFR therapies or immunotherapy. So that trial, like I said, is enrolling. Kind of at the same time as we were about to launch, Dr. Atreya at UCSF was interested in looking at kind of a BRAF MEK PD-1 combination in the same setting. So we've worked with her to kind of get these trials going up in parallel. I believe her trial is open now, and I think that they're kind of talking to her. They've been enrolling too. I actually don't know what the safety data is of this combination yet. I haven't heard that from her, but we presume that it's going to be well tolerated. So I want to circle back just to how we can learn from what we're doing in the lab and move that forward in this context as well. We love using PDX models at MD Anderson. Kind of as I've talked about earlier, we feel that these kind of help us to pitch concepts, to clinical trial, for clinical trials to, the NCI and pharmaceutical companies. And we've shown, again, in data that hasn't been published yet, that, what happens clinically to patients on BRAF EGFR therapies matches what happens in their matched mouse avatar. So we looked at 5 patients who were treated on the SWOG 1406 study and characterized them as, by their clinical response as either having stable disease or partial response. And what you can see is that the overall trends for the stable disease patients in the blue mirror that for what was happening in the matched mouse. Whereas what was happening in the patients who responded clinically to the combination, you see kind of greater reductions kind of in the tumor size in their mouse avatars as well. One of the interesting things, just kind of anecdotally, just to kind of point out here as well, is that in some of these mouse models, this this is like just looking at this one. This mouse is, the patient had a response to vemurafenib, arinacetux. You can see that in this mouse model for this matched patient, the BRAF EGFR, was it developed resistance. But then when we added the irinotecan, you see, a drastic reduction in in tumor size. There was also a trend towards the irinotecan being different than that of the BRAF EGFR. Similarly here, this mouse model, this patient responded to the combination. The mouse didn't really have benefit from irino alone, but when we added all three, we saw that there was improvement. So again, it may not be this may point just the one size doesn't fit all, and also kind of points to the fact that of this heterogeneity that I'm talking about. There is a trial that's being developed and moving forward, looking at chemo with or without encorafenib Cetuximab in the frontline setting. And I think that data like this kind of points to the idea that, hey, maybe there is some meaningful interaction with chemotherapy and targeted therapies in this context that we'll see. The problem is, when it comes to mouse models, these are, immunocompromised. So the ability to study, the encorafenib, nivolumab, cetuximab combination would be limited in traditional PDX models. So Dr. Canacarla in our group at MD Anderson's All-Star has worked to develop these humanized PDX models where tumor tissue from a patient in matched blood is used to create these mouse avatars. And we have funding that's through an early career SPORE award at MD Anderson to do a co-clinical trial for our study to look to see if what happens again in the patient mirrors what happens with the same treatment combination in a developed humanized PDX model. And likewise, if what you see happening immunologically in terms of changes matches what happens in the matched PDX humanized PDX model as well. This was funny. I got through the SPORE award. The mentor here is Jen Allison, who kind of won the Nobel Prize for his work in developing immunotherapy for patients with cancer, and it's been really exciting to have the opportunity to work with Dr. Allison on and get his input on the design and science of what's going on here. This is just kind of works showing some stuff we're doing with Dr. Kyusun Yun in collaboration with her on this trial. I would also ask this to be confidential and not shared as well, out of respect to her developing technology. But what we're doing is we're giving her slices of tumor from pre-treatment biopsies taken from patients on this study, and then she's slicing these tumors and putting them into individual plates, and we're testing what's happening, with various combinations. And this is a patient who responded on our study to the triple combination. And what we saw was that when she treated these small slices of the tumor with encorafenib cetuximab, by day 18, there was some reduction of tumor cell viability with the BRAF EGFR combination. When we added nivolumab to that combination, we saw a much deeper reduction in cell viability. I didn't put nivolumab here as well, but that bar was here, so you didn't see. It wasn't single agent nivolumab, down here either. So it was interesting to us because we felt that her model, could likewise, when you have the patient's own, immune cells present within the microenvironment, it may reflect what's happening in the matched patient, but also that there may be in some patients some meaningful benefit to the addition of nivolumab. So, I hope that I provided here some rationale for why adding immunotherapy to BRAF EGFR targeted therapies in an MSS BRAF mutated setting, makes sense when these patients historically have been unresponsive to immunotherapy alone. I think we're all encouraged by Dr. Corcoran's work, and our hope would be that given the recent FDA indication of encorafenib cetuximab, we could build upon that success with a similar approach, and are certainly working to that. And then I think that this will be informed further by preclinical and translational work that remains ongoing. I was asked just to talk a little bit about kind of atypical BRAF mutations in CRC. These are slides that I borrowed, full disclosure, from Dr. Benny Johnson in our group at MD Anderson, who really has led our group's efforts very valiantly to kind of work. This is kind of data as well. This is a slide I think that had come from maybe Dr. Yeager at Memorial. I'm just kind of showing kind of the different mechanisms, kind of the traditional RAS-independent BRAF V600E monomer we associate with the class 1, the dimerized BRAF mutants we see kind of with class 2, and then kind of the BRAF inert class 3s that kind of have characterized these more atypical BRAF mutations. Again, we recognize that that kind of, as you can see in all three of these slides, the atypical BRAFs tend to fare better than the BRAF V600Es. And I would say, I don't think that this is something that all oncologists, realize. It's not uncommon to get a referral or a call from an outside doctor saying, hey, I have a patient with a BRAF mutation, can I send them for your trial? And then we find out that it's like a D594G mutation, kind of one of these more atypicals. So I think this is something we're really trying to get the word out with oncologists as well, kind of as we learn more. And this is kind of, again, Dr. Johnson here, who I really just want to plug, I think has really had a passion for leading this effort, in our group at MD Anderson, but just kind of some of the novel approaches that we're trying to take at MD Anderson for kind of how we triage, patients to various trials according to their specific BRAF mutation, whether it's a V600E or a non-V600E. So that kind of sums up, what I had to say. I try to be active on Twitter, although it's if you have any questions, please just let me know.
Yes. So if I can, I'm going to start with questions. You can hear me, right?
Yes, I can.
Yeah. So you were talking about the heterogeneity, molecular. So I was kind of wondering, in the unpublished data that you have, can you say, so you said that one set was the MAP kinase signaling pathway, and the other one was a different, cell cycle and all of those pathways. So are you, in your different trials, are you attempting to find out what those different groups are? I mean, the reason I ask is, just like you said, we in our group, we find a lot of heterogeneity in how people respond to the different treatments for the BRAF V600E mutation. So it would make, sense to us if we could know what they were, because most of the people most of the patients, they already have their genomic testing done. And then, if there's some way to know upfront that you are in the 8.4-month category, not the 84-month category, then you can plan accordingly, how you have to prioritize treatment, right?
Yeah, so I think we're looking at that. We're certainly collecting data or we're collecting biopsies, to look at the transcriptome in RNA sequencing in these patients, and that may kind of inform on whether there's CMS classifications or BM1, BM2 classifications. I believe that Pfizer is looking at that on the patients who went on the Beacon study as well. So I think it'll be very interesting if you see here that the BM1 patients are the ones who maybe had more benefit with the triple, if there was a preferential added benefit with the addition of the MEK inhibitor to the BM1s than the BM2. So I'm very interested in this question as well, and I hope that we'll get some information from Pfizer about that. I think that Corcoran had published from his kind of triplet, the dabrafenib, trametinib, panitumumab work, earlier this summer in clinical cancer research, some signal kind of saying that. But I think kind of it'll be very interesting in a larger cohort in a randomized trial to look at that in a kind of post hoc analysis.
Mm-hmm, mm-hmm. And then my other question would be there is this test called immunoscore, right? Do you think those kind of tests can tell you more? I was kind of wondering that if there was any efforts to develop some kind of assay so that you can look at a BRAF patient and say that, this would be more BM1 or BM2 or, even the consensus molecular subtypes. Do you know if there is something like that being developed or going on?
I mean, not that I'm aware of. I'm sure that it probably is being worked on. It's a really good point. But it's not something that we're actively working on now.
Okay. And then the person that you're collaborating with, Q-Sin Yun, the tissue culture thing. So it's entire section of the biopsies is grown in the bowels, and you're seeing that when you try the combination treatment with the immunotherapy, just with that, not inside an animal, you're still seeing a response, right? That's what you said.
Yeah, that's right. So, I mean, again, we've put only 11 patients on our trial thus far. And I mean, in full disclosure, with the pandemic, we had to shut down, understandably, all optional, we decided to shut down all optional biopsies, for several months. So this limited our ability thus far to look at this in high numbers, but it is something that kind of we're opening back up now, and we'll be kind of looking, more stringently to see, is there a signal? It's, you always see kind of in these presentations the N of 1, so it's hard to know for sure if that's truly representative or if, people cherry pick, the best story to show. I don't know.
Okay. And then you'll have some, I'm hoping that you'll have some results by GI ASCO. Is that, is it hopefully?
Yeah, I mean, if so, it would be a late-breaking abstract. I think we have 26 patients, that we would plan on putting on study. So we're just about halfway there. So it would either be a late breaking or probably the ASCO next year. We'll see.
Okay.
But we're moving forward, and we've talked to the NCI about, what a next step would look like, in a more definitive fashion.
Okay. So thank you. Let's see if others have questions. Questions, anyone?
No, I feel like I need to listen to this all again and consume it. There's so much information here. It's been very helpful. But I was really interested to hear about, some of the other mutations, that we're seeing that are driving when BRAF, kind of becomes, less important. So, I kind of feel like I need to review all of that again because I don't think I caught it all. But, any other thoughts you have around that and how we should think about, how does treatment progress as you, maybe get to the end of what targeted BRAF can do? How do you make the decision to move forward from there?
Yeah, I mean, I think it's a really good question. I think one of the things that hasn't been fully looked at yet is, with what you see in a RAS wild type setting where there's this idea of, anti-EGF, these patients develop these acquired RAS, KRAS, NRAS mutations. And then when you pull away the anti-EGFR therapy, that selective pressure is lost, and that acquired mechanism of resistance decays back down. Dr. Christine Parsegian in our group, had a really nice paper just kind of showing the kinetics of and the acquired resistant setting to anti-EGFR therapy. The median half-life is about 4 to 5 months. So by the time you see 50% of that acquired resistance mechanism go away, and then you can re-challenge these patients and see some benefit. And that's being looked at in multiple clinical trials right now. And then the question is when a patient progresses on BRAF EGFR therapy, is that the end, ever in their story and journey for BRAF EGFR therapy, or is there a role for rechallenge? None of us knows that, and I think it would be really interesting to look at. So I mean, yeah, like I think that's something we've thought about, and I'm not aware of any data out there that's shown that that's successful or not successful.
Rashmi?
Great, thank you.
Mm-hmm.
Thank you, Manju. Dr. Morris, my name is Rashmi, and I'm a caregiver to my husband with BRAF. My question to you is, we know the pathway of the BRAF for the EGFR and the MEK and the ERK. Looking at the 3 trials between Dr. Corcoran's, Dr. Kopitz, and Dr. Atrea's, it seems that the BRAF and the immunotherapy are similar. What's different is the EGFR versus the MEK. Would you speak something to that? Is there I mean, your study is leaning towards the EGFR versus Dr. Corcoran's is looking more at the MEK inhibitor?
Yeah, I mean, I think that what he's seeing, and the rationale for why we did what we did was was similar. I don't think that we know that that BRAF EGFR PD-1 is any better or worse than BRAF MEK PD-1. I think for us, we realized several years ago that with the SWOG data that probably BRAF EGFR was going to get approved, and in how we were going to be able to develop a strategy to, if successful, to roll this out to our patients. It made sense in the context of a BRAF EGFR setting. So that's why why we kind of went with that approach years ago, and it I don't know, like, why he had done a lot of work in the BRAF MEK. I mean, I can't speak to why they chose that, but I don't think that we know that there's a difference, or why or if there's a difference.
Thank you.
Okay. Again, I'm going back to the CMS1 and CMS4, subtypes. So in our group, we have patients. We have one patient who's been almost NED. She's been on the Beacon triplet, and she's that one patient who has gotten a phenomenal response. For most of the patients, we see that they are on the triplet for a certain time, and then things start growing, and then they get back on FOLFOX, FOLFIRI plus Bev, and that seems to work really well. So we have a group of patients for whom the FOLFIRI plus Bev or FOLFOXIRI plus Bev seems to give the best response. So again, I was kind of wondering whether that goes back to what you said about the MAP. BRAF MAP or its pathway being important versus the cell cycle one, because then in that case, the cell cycle one would be more susceptible to chemo, right?
Yeah, I mean, in theory, yes, but I mean, just kind of given the fact that these patients don't respond in a treatment or refractory setting very well to chemotherapy, whether that translates into clinical reality, I don't think we know yet.
Okay. So again, like, my push would be to, if there could be an assay to tell you what kind of BRAF you are from a patient perspective, that would make a big difference to patients as to how they approach the different treatments.
Oh, it would help us too. Yeah, I mean, I think we're very interested in understanding the different biologies, because again, we recognize it's not a one-size-fits-all approach here.
I think if there are no more questions, thank you very much for your time. And I guess that people, there are about 250 members. Many of them will watch the video because we're going to post it in our group, and then there may be more questions. So then I'll probably get them to you either by email or on Twitter. And thank you so much for your time.
Oh, thank you. I appreciate it so much.
Okay. Bye.
All right. Bye.
Thanks, everyone.